Welcome to the Charted Defense. I'm Michael Coleman, and today we will do a deep dive into one of the cases we discussed on our last episode. Why do some patients with hyponatremia overcorrect? Why do some patients not only overcorrect but also don't respond to our attempts to re-lower their sodium level? Then we will go through the Supreme Court decision related to that malpractice case to illustrate how courts look at malpractice cases. I'm glad you are here with us today. Let's begin the show.
A middle-aged man with heavy alcohol use comes to the ED with nausea, vomiting, diarrhea, imbalance, and slurred speech. His sodium returns at 96, profound, life-threatening hyponatremia. He receives IV saline. Over the next day, his sodium rises quickly. A week later, he's diagnosed with central pontine myelinolysis, now more broadly called Osmotic Demyelination syndrome. Today I'm going to do two things. First, we'll break down the physiology of why alcohol-associated hyponatremia can overcorrect explosively, how to anticipate it, how to detect it early, and what the neurologic time course looks like when things go wrong. Second, we'll pivot to a published court decision, Harrison versus Binion, and translate how the court analyzed causation in a way that makes sense to clinicians. This podcast is for education only. It's not personal medical advice, and it's not legal advice. Hyponatremia management is nuanced, and local protocols vary. Use your institution's guidelines and consult nephrology or critical care early in high-risk cases. Let's start with the most important habit in hyponatremia. Don't stop at the number. Sodium 96 tells you it's severe, but the mechanism tells you how it will behave once you start therapy. In the case we're discussing, the opinion describes a history of weeks of vomiting and diarrhea and, critically, several days of consuming only alcoholic beverages. That history points to a high probability combined mechanism. The three combined mechanisms likely at play here include: the first mechanism, low solute intake, also known as beer potomania. Physiology: beer, and many spirits, provides lots of free water but very little solute, especially very low sodium and very low protein. The kidney's ability to excrete free water is limited by how much solute it can excrete per day. In other words, you can only make a very dilute urine down to a floor, say approximately 50 to 100 milliosmoles per kilogram in many patients. Your maximum urine volume approximately equals daily solute excretion divided by minimal urine osmolality. If daily solute intake is extremely low, common in malnourished heavy drinkers, your maximum urine volume may be only a couple liters per day. Any water intake above that becomes retained, driving serum osmolality down and causing hypotonic hyponatremia. This is why beer potomania is really a low solute hyponatremia problem, not an alcohol problem per se. The second mechanism, hypovolemia-stimulated ADH, beats vomiting/diarrhea. Now layer in the GI losses. Vomiting and diarrhea cause effective circulating volume depletion, which triggers non-osmotic arginine vasopressin, AVP/ADH, release. When ADH is elevated, the kidney reabsorbs water and urine becomes less able to dilute. That makes hyponatremia worse, especially if the patient continues drinking low solute fluids. And finally, the third mechanism, nausea and pain as potent ADH stimuli. Even without frank hypovolemia, nausea is one of the most powerful ADH stimuli in clinical medicine. Alcohol-associated gastritis, withdrawal, and stress can all contribute. Put together so clinically, this patient likely had Low solute intake leads to impaired free water excretion, plus non-osmotic ADH from hypovolemia/nausea leads to water retention, producing profound hypotonic hyponatremia. One more clinical pearl. In chronic hyponatremia, the brain adapts by losing electrolytes and organic osmolytes over days. That's why patients can look not that sick neurologically, even at very low sodium. And it's also why rapid correction becomes dangerous. The next concept is the one that gets clinicians into trouble. Hyponatremia often autocorrects. And in alcohol-associated low solute and / or hypovolemic states, the autocorrection can be dramatic. A. Volume repletion can abruptly switch off ADH to water diuresis. If hypovolemia is a driver, giving isotonic saline restores effective circulating volume. Once euvolemia is restored, the non-osmotic ADH stimulus disappears. ADH secretion can drop rapidly, and the patient can develop a large, sudden water diuresis. That diuresis is what drives sodium up quickly, sometimes far beyond what your formulas predicted. B. Adding solute unlocks free water excretion in low solute hyponatremia. In low solute hyponatremia, beer potamania physiology, giving saline or simply resuming a normal diet raises solute delivery and solute excretion, which increases the kidney's capacity to excrete free water. The kidney suddenly becomes capable of producing much larger volumes of dilute urine. Again, sodium rises fast. C. Potassium repletion can raise serum sodium. Alcohol-associated hyponatremia frequently coexists with hypokalemia. Correcting potassium can contribute to a rise in measured serum sodium and tonicity. D. Why prediction formulas fail. Even if you calculate expected sodium change using standard equations, real patients can exceed the predicted rise because the underlying physiology changes midstream, especially when ADH turns off and urine output jumps.
The clinical translation: in the malnourished alcoholic with vomiting/diarrhea, the treatment itself, saline, nutrition, K repletion, can trigger a physiologic phase change from water retention to water excretion. That phase change is what causes unexpected rapid correction.
How to identify patients prone to overcorrection before you start treatment. Before you hang the first liter, you want to ask two separate questions. 1. How likely is this patient to overcorrect? 2. If they do overcorrect, how vulnerable are they to osmotic demyelination? Those are not identical. A. Clinical phenotypes that tend to autocorrect high-risk etiologies for sudden water diuresis include hypovolemic hyponatremia, vomiting/diarrhea, poor intake. Once volume is restored. Low solute intake, beer potamania/tea and toast/malnutrition. Once solute is introduced. Reversible SIADH triggers nausea, pain, some drugs. When the trigger resolved. B. History clues, fast, bedside. Only beer/alcohol or almost no food for days. Marked recent vomiting/diarrhea. Thiazide exposure, not in this case, but high risk in general. Malnutrition, low body mass, liver disease. Alcohol use disorder. C. Labs and urine studies that raise your suspicion if you can get them before significant fluids. Urine osmolality. Very low values suggest ADH is suppressed or about to be suppressed, which can herald a water diuresis and rapid correction. Urine sodium/solute profile. Low solute intake can show low urine solute excretion. Low urea generation, low protein intake is a classic context in alcohol-associated cases. Electrolytes. Hypokalemia is both a marker of vulnerability and a contributor to correction dynamics. D. vulnerability to osmotic demyelination, ODS risk. Regardless of the cause, some patients are simply at much higher risk of neurologic injury if sodium corrects quickly. High-risk features include very low starting sodium, classically less than or equal to 105. Chronic duration, often unknown, default to chronic unless clear acute water intoxication. Alcohol use disorder, malnutrition, hypokalemia, advanced liver disease, classically a risk group.
If the patient is both, 1, likely to water diurese, and 2, high risk for ODS, treat the situation like a high-hazard medication infusion, controlled correction, close monitoring, and a plan to prevent or reverse overcorrection.
Acute signs that a patient is overcorrecting. This is key. ODS symptoms are delayed. So the acute signs of overcorrection are usually physiologic and laboratory signs, not neurologic ones. Urine output suddenly rises. A brisk, unexpected rise in urine output, especially sustained, often signals that ADH has dropped and the patient has entered a water diuresis phase. In practice, this can look like hourly urine output suddenly climbing, sometimes several hundred milliliters per hour. Urine becomes dilute. If you're checking urine osmolality, a drop to very low values supports the same conclusion. Water diuresis is underway. Serum sodium rises faster than your limit. The core operational definition is the sodium is rising faster than intended, particularly if it is on track to exceed daily limits. The feel-good trap. Sometimes the patient looks clinically better as sodium rises and volume status improves. Less nausea, more alert. That can create a false sense of safety while the sodium trajectory is becoming dangerous.
High-risk patients should be treated in a setting that allows frequent sodium checks, often every 2 to 4 hours early, strict I and O and close monitoring for water diuresis, a predefined plan to stop offending fluids, and, when indicated, use measures to control or re-lower sodium if correction limits are exceeded. This is my medical opinion and not intended to be medical advice or legal advice. Follow up-to-date medical evidence and your hospital's protocols and policies.
Now, let's talk about what happens when correction outpaces brain reaccumulation of osmolytes. Why the injury is delayed. In chronic hyponatremia, brain cells adapt over days by extruding electrolytes and organic osmolytes to prevent cerebral edema. When serum sodium is corrected too fast, extracellular tonicity rises quickly. Water shifts out of brain cells, and that rapid shrinkage is associated with injury to glial cells and demyelination. Typical symptom timing: 2 to 6 days after overcorrection. The classic teaching, and what clinicians see, is a delay. Patients may initially improve, then develop new neurologic deficits days later. Clinical syndromes. Symptoms can include dysarthria and dysphagia, paraparesis or quadriparesis, movement disorders, behavioral changes, confusion, obtundation. In severe cases, a locked-in state, awake but unable to move or communicate. ODS can involve the pons, historically CPM, and/or extrapontine regions. Imaging often lags. MRI can lag behind the clinical syndrome. A negative early MRI does not rule it out. Repeat imaging may be required when suspicion remains high.
With that physiology in mind, let's walk through the timeline described in Harrison versus Binion, an Idaho Supreme Court decision filed July 7, 2009.
This is a publicly available, published court opinion. I have redacted the names of the parties involved as this is more of an educational podcast. The point here is to understand how medicine and law intersect and how the cases progressed through the courts. The opinions below are those of the courts and not my own. I do not claim any extra knowledge of this case outside of the publicly available information. On November 14, 2003, around 11:35 p.m., the patient arrived at the ED with nausea, vomiting, diarrhea, imbalance, and a speech impediment. The history described deterioration over 7 weeks with frequent vomiting and diarrhea. And his partner reported that for the prior 3 days, he had consumed only alcoholic beverages. An ED physician evaluated him around 1 a.m. Lab results returned around 12:49 a.m. with a sodium of 96 mg per liter, which the opinion describes as life-threatening. The ED physician ordered IV saline at 200 cubic centimeters per hour, started around 1:50 a.m. She called the on-call hospitalist physician around 2:25 a.m. The hospitalist agreed to admit. The ED physician suggested telemetry. The hospitalist preferred a medical floor environment, and the ED physician wrote the admission orders on his behalf. The admission orders included continuing IV sodium at 200 cubic centimeters per hour and obtaining a Chem 7 every 6 hours. The patient was admitted at 3:26 a.m., at which point the opinion states the ED physician was no longer responsible for his care. The hospitalist first saw the patient at 11:17 a.m. on November 15th. A second Chem 7 drawn at 6 a.m. showed sodium 105. After reviewing the chart and examining the patient, the hospitalist continued the plan. IV sodium at 200 cubic centimeters per hour and Chem 7 every 6 hours. The sodium continued to climb. 110 at 12:27 p.m. on November 15th. 114 at 5:58 p.m. on November 15th. 124 at 3:57 a.m. on November 16th. 126 at 10 a.m. on November 16th. The court opinion notes that the patient's condition continued to deteriorate under the hospitalist's care. And on November 22, 2003, another physician diagnosed central pontine myelinolysis, described as myelin sheath destruction in the brainstem, and attributed in the court's opinion to too rapid a change in sodium. Now the legal side, in physician language. The cause of action. The lawsuit was filed in 2004 by the patient and his spouse against the hospitalist physician, the emergency room physician, and the hospital, alleging negligence in treatment, medical malpractice, and negligent and intentional infliction of emotional distress. Later, plaintiffs tried to amend the complaint to add a claim that the hospital negligently credentialed a physician, essentially arguing the hospital was negligent in granting privileges. The procedural posture. The case that reached the Idaho Supreme Court was an appeal from several district court rulings, including 1. Denial of the motion to amend to add negligent credentialing. 2. Rulings limiting discovery of certain personal physician records. And 3. Summary judgment in favor of the emergency room physician. The plaintiffs eventually dismissed claims against the hospitalist with prejudice after an out-of-court settlement, and later dismissed remaining claims against the hospital, leaving the key appellate issue, clinically and educationally, for us. Why summary judgment for the ED doctor was affirmed. How the court analyzed causation. Why the ED doctor was not held liable. This is the part that maps well to clinical reasoning. In malpractice, you typically need duty leading to breach, leading to causation, and finally the damages.
Clinicians tend to focus on breach. Did someone correct too fast? Courts often turn on causation. Did that specific clinician's conduct more likely than not cause the injury?
Step 1. The court said causation here requires expert testimony. The Idaho Supreme Court held that whether a rise in sodium in a specified amount over a specified period of time would cause CPM is not within common lay experience. So the plaintiff needed admissible expert testimony on causation. Step 2. The court assumed breaches for summary judgment purposes, but still required causation proof. For purposes of the summary judgment analysis, the opinion states it was assumed the ER doctor breached the local standard of care in several ways, such as incomplete communication to the hospitalist, not putting certain warnings/communication instructions into orders, and not slowing correction rate. But the key question became, is there evidence those presumed breaches were a substantial factor in causing CPM? Step 3. The expert's causation opinion lacked a sufficient factual basis. The opinion explains that the only testimony tying ER doctor to CPM causation came from the plaintiff's expert doctor. A. The court evaluated whether the facts underlying his opinions actually supported the causation conclusion. Clinician translation. The court didn't accept rapid correction can cause CPM as enough. It wanted a medically grounded chain like, if the ED physician had done X instead of Y at time T, the sodium trajectory would have been within safe limits, and CPM would more likely than not have been avoided. The court's analysis repeatedly emphasized that. The hospitalist reviewed labs and chose to continue the infusion plan when he evaluated the patient later. The ED physician no longer controlled care after admission, and some alleged breaches were not legally attributable. For example, ICU admission decisions when the ED physician lacked authority to admit. Bottom line holding, as a clinician would phrase it. The court effectively said, even if you assume the ER physician deviated from the standard of care, the plaintiffs did not produce sufficiently grounded expert testimony that the ER physician's deviations were a substantial factor in causing CPM, so the causation element failed, and summary judgment was appropriate. A useful way to think about this as physicians is, the court required a causation argument with the same rigor you'd expect in a morbidity and mortality conference when attributing a specific outcome to a specific decision. Only here, it must be framed as a legal proximate cause and supported by admissible expert testimony.
In other words, regardless of whether the ER physician's care constituted a breach, the actions of the hospitalist physician in continuing the IV fluids at the same rate showed the court that the ER physician's care would not have likely been the causative reason of this patient's outcome. Now, what are the final take-home points from this case?
5 takeaways to keep you out of trouble clinically and, frankly, medico-legally. 1. In alcohol-associated severe hyponatremia, assume a mixed mechanism. Low solute plus non-osmotic ADH from volume depletion/nausea. That combination is a setup for autocorrection. 2. Watch for the phase change. Once ADH drops and solute increases, urine output can spike and sodium can rise faster than predicted. 3. Before treating, identify both. Likelihood of water diuresis and vulnerability to ODS, Na less than or equal to 105, alcohol use disorder, malnutrition, hypokalemia, chronicity. 4. The earliest sign of overcorrection is usually urine output and labs, not neurosymptoms. Monitor aggressively. 5. ODS is typically delayed by days. If a patient has new dysarthria, dysphagia, quadriparesis, altered behavior or locked-in physiology after rapid correction, treated as ODS until proven otherwise, even if early MRI is negative. And from the legal side, malpractice isn't only about whether a bad outcome is consistent with an error. It's about proving a specific clinician's conduct was a substantial factor in causing that specific harm, typically through expert testimony.
I hope you found this deep dive informative and helpful. Join the podcast and share with your friends. We will look at many other cases such as this in the near future. My goal is to educate and learn so that we make medicine safer for all of us. The opinions here are my own and not to be taken as official medical or legal advice. The opinions described by the Supreme Court in the case breakdown are the opinions of the court. I am not here to dispute any claims or lay blame on any person. See you next time.